In this study, Sonrotoclax has been given to 97 patients so far with CLL in this combination. It's part of an overarching study, the MBChB 11417101 clinical trial, which uses the Sonrotoclax in combination with zanubrutinib or as monotherapy for other low-grade lymphoproliferative disorders as well as CLL. So this is just the cohort of relapsed refractory CLL. So the patients receive 3 months of zanubrutinib before starting a Sonrotoclax ramp up. In this cohort, there were numerous sub-cohorts of different dosing of Sonrotoclax from 40 milligrams up to, I think, 640 milligrams. At follow-up, which I think data cutoff was around October last year, that was around 19 months, the median follow-up. We had good overall response rates, which improved with time. CR/CRI response rates increased at 48 months compared to the 24-month cutoff as well, and MRD was also assessed, which also deepened with time. Side effect profile-wise was things you'd expect with these agents. Neutropenia, some COVID infection, contusions was common. There were no incidents of atrial fibrillation in the cohort. One patient had to come off study after developing cryptococcus, but all other patients continued on. I think one patient in the lowest dose group came off study with progression. With the treatment-naive cohort of CLL patients, again, this was in the 101 Beijing study using combination Sonrotoclax and zanubrutinib, again with a 3-month zanubrutinib lead-in to reduce risk of TLS, and then the ramp up in 2 dosing cohorts, 160 and 320. There were around 47 patients in the treatment-naive cohort. They again had really good response rates, which deepened with time. Overall response was 100%, broken down into CR, CRI, and a PR. Undetectable MRD down to MR4, also deepened with time. It was 100% in the 320 cohort at 48 weeks, but again, this was just one patient. So similar adverse effects with neutropenia, contusion, no atrial fibrillation, and no other cardiac comorbidities or complications. So overall, really promising. Sonrotoclax as a BCL2 inhibitor is more potent than venetoclax and with less off-target effects. So hopefully it will be applicable to the patient population if it does get approved.